Cysts are things that we tend to worry a lot about, so I'm going to give you a framework for how to worry or not to worry. Cysts that aren't simple are more common because of higher frequency and more haze, broader band with higher dynamic range, but also because our resolution's better and we're seeing real stuff that exists inside a fibrocystic change. Every fibrocystic change arises from the TDLU. A normal TDLU looks like this. Inside this TDLU are maybe up to 50 or 60 acini. So the earliest changes are the acini filled with fluid become black, and the normally gray loose stromal tissue becomes white. So it's cystic and fibrous change. That's why they call it fibrocystic. It's not just pure cystic change. As the degree of fibrocystic change gets worse, the acini get bigger and the walls between them rupture, and ultimately you can wind up with a simple tension cyst, usually because of twisting of the duct. Well, we don't have any problem with normal TDLUs. We don't have any problem with simple cysts. But in between here, we can have problem because this white fibrous tissue can volume average with the black microcysts. And the microcysts can be narrower than the beam, so if you volume average white fibrous tissue with black cysts, you get gray tissue. And especially if you have low-end machines, this can look like a mural nodule or a thick septation. So, you know, the main value I found in higher-end ultrasound machines is not necessarily that they find more cancers, but that I can call things benign with greater degree of certainty. We've found ways to work around lesser quality ultrasound machines in terms of sensitivity, but it's really hard to call things benign on a low-end machine because these microcysts invariably make it look like a solid nodule. Found the same thing in the thyroid. These, the little microcysts, the spongiform microcysts can't be resolved on a low-end machine, but can be resolved on a high-end machine. Now, why do we get all these echoes inside a cyst? Well, there's lots of causes. Volume averaging of black microcysts with white fibrous tissue, fat or protein in the fluid, papillary apical metaplasia, usual duct hyperplasia, fibrosclerosis, or uneven distribution of estrogen receptors. And then you can also have ADH, ALH, and LCIase and malignant causes, carcinoma in situ. This is an estrogen stain on a TDLU, and you can see that the estrogen, the brown stain where the estrogen exists, those are large acini. The ones that don't have estrogen receptors don't distend. So here you can see 3D pictures that are color and then turned to black and white and reversed. And you can see the large acini that have estrogen receptors and those that don't. And on ultrasound, these look like complex clustered microcysts. So they look more concerning, you know. Simple clustered microcysts you can call BI-RADS 2. Unfortunately, complex microcysts, you often have to call BI-RADS 4 or 3, depending on whether they're clinically or mammographically evident or they're incidental and multiple and bilateral. So it shows one of the problems we have. Now, complicated cysts in the ACR BI-RADS category, usually BI-RADS 2 or 3, and they're just stuff that's inside a cyst, diffuse low-level echoes from protein or fat, scintillating echoes from cholesterol crystals, debris levels, fat fluid levels. And complex cysts are more concerning because they have true solid components in them, mural nodules, thick septations, or thick irregular wall. And to that I would add internal vascularity. What the ACR BI-RADS doesn't mention is that we still have cases where we're just not sure whether they're cystic or solid. I mean, you'd think in this day and age that wouldn't happen. We have cases we don't really know whether they're cystic or solid. I'll show you some techniques for figuring that out. Now, this is what we're worried about in cysts, and this is what's mostly there. And the pathologist can give page-long descriptions of all these things on the left. But in the end, he says benign fibrocystic change. So what the rest of this talk is about is how we as radiologists and sonographers can do the same thing. Look at these cysts with gunk in it and say, oh, it's just fibrocystic change. Now, this is fluids that come from benign breast cysts. And you can see they vary greatly in color. And if I make a grayscale and video invert it so white's black and black is white, you can see that the opacity varies greatly. So let's assume the medium level opacity is a simple cyst. We've got some that are denser, so there has to be something in there other than water, and that's protein. That's proteinaceous debris. And some are less dense. They have to have fat in them. So fat or proteinaceous fluid can make the fluid echogenic. And that's some of the reason we can't tell cyst from solid in some cases. Now, how does that happen? Here's a simple cyst. She was actually being followed for a fibroadenoma somewhere else. But 6 months later, she's still simple. But a year later, now she's got diffuse low-level echoes. Why is that? Well, she always had either fat or proteinaceous debris in that cyst, but it wasn't concentrated enough for us to see. But over time, the fluid gets resorbed through the epithelium of the cyst, but you can't resorb the protein or fat, so it becomes more concentrated over time. Now these are all things that pathologists would call just benign fibrocystic change. This is a simple cyst with proteinaceous debris, single layer of apricot cells with fatty fluid, apricot cells secrete fat, and then papillary apricot metaplasia with fatty fluid. These are the grayscale video inverted pathology images, and these are ultrasound images. So you can see why I take the color pathology images and make them black and white and then video invert them. This is a simple cyst with a thin wall. This is a complicated cyst with low-level echoes and a thin wall. This is a complicated cyst with a little thicker grayer wall because of the apricot metaplasia. And this one has an irregular thick wall with low-level echoes. So the one on the left simple, the two in the middle are complicated. The one on the right is both complicated and complex, but just like solid nodules, when we see a mixture of more suspicious and less suspicious findings, we go with the more suspicious findings, so we call it complex. Now we have to have a systematic approach to this, so we like to eliminate artifacts. So we want to avoid volume averaging, and we want to get rid of artifactual echoes caused by high dynamic range. So we can use a combination of good focal zone placement, digitally encoded harmonics, and spatial compounding. So here's a small near-field cyst that appears solid because we've got our focal zones too deep. Remember, it's inside 10 millimeters. In fact, it's about 5 millimeters. The beam is wider than the lesion at that point. I can either use a standoff, but before I do that, I should get my focal zones at the right level. And when I get my focal zones at the right level, I can see they're simply clustered microcysts. This is without harmonics on the left, with harmonics on the right. Harmonics clears out artifact. And the same thing happens with spatial compounding. Now, the ACR will not accept images with harmonics turned on. The ACR, again, couldn't be more wrong. There are 3 flavors of harmonics. There's digitally encoded, pulse inversion, and swept wall filter. The swept wall filter indeed does destroy axial resolution, but these other 2 maintain or even improve spatial resolution. So if you know what kind of harmonics you have, it actually improves your resolution. So the ACR is absolutely categorically imperatively wrong. Who's ever refusing to accredit institutions because they have harmonics on should be fired, but it's not going to happen. So for heaven's sakes, don't submit an image to the idiotic ACR commission with harmonics on because they won't accept it. They don't know physics at all, I'm sorry. It's my organization. In general, it does more good than harm, but sometimes they just don't get it right. Now, this is spatial compounding on the right. On the left, we don't have it. You can see that spatial compounding clears it. My preference in diagnostic mode is to have both spatial compounding and harmonics on. I will tell you that in screening mode, I turn harmonics off because I get too much artifactual shadowing, too many false callbacks. But in diagnostic mode, it works 95% of the time, and I can just hit the button and turn it off if I'm getting what I feel is artifactual shadowing. Now, when you use these 2 techniques, real echoes build up. So this is a real complicated cyst, and with harmonics, the echoes are greater. So I've had people say, I don't like harmonics, puts echoes in cysts. Well, it's real echoes. You know, I just want to know what's real and what isn't real, and then I'm going to solve the problem from there using elasto or streaming or whatever thing I can. So general rules are very reassuring. The majority of non-simple cysts simply are part of the fibrocystic spectrum. Malignant cysts are relatively infrequent. The unusual malignant cyst usually doesn't even look cystic. It looks like a solid nodule with liquefactive or hemorrhagic necrosis. Only in the rarest of circumstances do we find cysts tricky. Having said that, general rules are never reassuring to the population, because if you ever scan nurses or doctors' wives, they'll tell you, look, you'll say, oh, there's a 1 in a million chance, and they'll look you in the eye and say, yeah, but I'm the 1 in a million. Everybody's assured they're an exception to the rule. So general rules aren't very good. You still have to have a systematic way of evaluating these things. Now, the gold standard was difficult for figuring out a method to characterize cysts that weren't simple, because the gold standard was terrible. It was either cytology, fluid cytology, which has got a lot of false positives and false negatives, or was follow-up, and about 80% of the patients never came back because the cysts went away. So it wasn't very good. It wasn't until we could do ultrasound-guided directional vacuum-assisted biopsy and take out precisely and only what we were worried about that we began to get a feel for how to characterize these things. So we didn't want to reinvent the wheel. We used the same algorithm we used for solid nodules. We look for suspicious findings first. If one is present, we call the whole lesion suspicious and we biopsy it. If nothing's present, we try to call it BI-REDS 3, and if or BI-REDS 2, and if we can't call it BI-REDS 2, then by default we'll go back and call it BI-REDS 3. What you want to do is call as many of these BI-REDS 2 as possible. If you let these cysts plug up your system, you're going to be a bad radiologist. I mean, PPV3 is an important thing, and you just can't be wasting too many resources taking care of fibrocystic change. It's important to be able to call as many of these BI-RADS 2 as possible. So what are the things that make a cyst suspicious? Well, they're simply the same things that the ACR BI-RADS lexicon defines as complex. Mural nodules, irregular wall thickening, thick isocoacceptations, and to that I would add some internal vascularity, and certain clustered microcysts. So thinly septated cysts aren't worrisome. What is this? This is a single TDLU with 3 cystically dilated acini that remain. This, on the other hand, is a thick isocoacceptation, and that's suspicious. That could just be apricot metaplasia, but it could be DCIS or invasive cancer. So thin septations that are hyperechoic, not suspicious. Thick isocoacceptations are suspicious. Now, what about eccentric wall thickening? That's usually going to be apricot metaplasia. But in order to know whether it's suspicious or not, we have to think about how it forms. So our differential diagnosis here is going to be just garden variety papillary apricot metaplasia, which is benign fibrocystic change, versus a papillary lesion. Well, the papillary lesion forms inside a duct or TDLU, and then secondarily obstructs the duct and secretes fluid, so it usually creates its cyst distal to itself. And so what that means is that there will be a thin echogenic capsule around the distal part of the cyst, away from the nipple, but where it arose, there'll be a defect, because that's where the papillary lesion lies, and then there'll either be a duct extension or multiple duct extensions or irregularities. So you look at where the mural nodule's attached, you go toward the central end, toward the nipple, and you look for absent capsule and duct extension or irregularity. So what are the things there? Angular margin, loss of capsule, protrusion beyond the cyst into a duct, and a fibrovascular stalk. So here's a complex cyst, but it has a thin echogenic capsule all along the point of attachment, and it's confined to a nice oval shape. This one, on the other hand, has an absent capsule and irregular margins where it's attached. So that's suspicious. And that was a hemorrhagic papilloma, not a cancer. Again, this one is a perfect oval shape, thin capsule all the way around. This one has absent capsule and it has a duct extension coming out. That's suspicious. The one on the left is reassuring. And we can see how that happens. Now, it's important to look in the tissue surrounding the lesion. If you get an absent capsule and there's DCIS, many times there's more going on in the surrounding tissues than there is inside the cyst itself. Here we've got extensive branch pattern going on. So once you see that that capsule is absent along the point of mural nodules, take your eyes outside the cyst and look for non-mass findings or weak findings in the surrounding tissues. Now, the vascular stalk never develops in apricot metaplasia, so if we see it and we know it's a true papillary lesion, we don't know whether it's benign or malignant. If we don't see it, it doesn't help us as much. Doppler's always more valuable when it's present. Papillomas and papillary lesions often undergo hemorrhagic infarction, so this could still be a papillary lesion, but if we see a vascular stalk in it, it should be BI-RADS 4 or higher. Once we decide that it's a true papillary lesion, we're not very good at telling benign from malignant. In general, malignant lesions have multiple feeding vessels, benign lesions have a single feeding vessel, but I can't tell you how good that finding is. It's just something I've noticed over the years. Now, what we talked about earlier was the pure cystic pathway, but there's a pathway of benign proliferative disorders and fibrosclerosis. So we can get many complex clustered microcysts from fibrocystic change, and some of it's just volume averaging. Now, here's what it would appear to be complex clustered microcysts on ultrasound. On the left is micropapillary carcinoma in situ. On the right is papillary apricot metaplasia. When I make those grayscale and video invert them, they don't give you a warm fuzzy feeling, and on ultrasound, similarly, not a warm fuzzy feeling. Here's clustered microcysts. It's got a suspended microcalc, which is a little suspicious. This was thought to be probably benign. The patient was going to be put in 6-month follow-up, but she was told to examine herself and come back sooner. It was 14 millimeters. 7 weeks later, it was 33 millimeters. This is micropapillary carcinoma in situ. At the day of needle loc, it was 5 centimeters. So it had grown from 14 millimeters to 50 millimeters in 10 weeks. Why did we not do the first exam that we should have done? Micropapillary carcinoma in situ is one of the most vascular of all lesions. Had we put on Doppler and seen a lot of internal vascularity, we would have probably called that first lesion 4A rather than BI-RADS 3. It's very pressure sensitive, so if you scan too heavy, you can occlude the vascularity. You need to specifically scan so lightly that you take most of the weight on your little finger in hypothenar eminence, and you lift up on the probe so you're barely touching the skin if you want to use Doppler for characterizing these things. I don't think people have emphasized enough how critically pressure sensitive Doppler findings are. Once you've decided a cyst is suspicious, cytology is not good enough. You really need histology, and I would never, ever core biopsy one of these. Every complex cyst should be vacuumed. I don't care whether they pay you or not. If you're in a freestanding clinic, they don't pay you enough to justify doing it, but there are some cases you just need to do the right thing, and the right thing is to put the darn vacuum probe below it and vacuum the whole thing out, whether or not you get paid for it. You need to do the right thing. This is an example of a suspicious complex cyst. Here's the aperture underneath it, and now it's gone, and I've deployed a marker. I always should deploy a marker. In case I get atypia or malignancy, I got to get back and resect it. Once you've taken the fluid out with aspiration, it can be very difficult to find these things. Do I ever aspirate them before I do the vacuum biopsy? Yeah, but I do it under direct real-time guidance so that I know what the residual looks like, and I'm immediately prepared to go to vacuum biopsy. Now, one other thing can make a cyst look suspicious, and that's inflammation. There are 3 findings we see in inflammation at the thick uniform isoechoic wall, fluid debris level, and hyperemia of the cyst wall. Usually all 3 exist together. This is what a simple cyst looks like. This is what an inflamed cyst looks like. It has uniform isoechoic wall thickening. It's really not the wall, it's pericystic inflammation, and a debris level, which is leukocytes or white cells. And these are actually macrophages in this case causing the uniform wall thickening. Fibrocystic change usually doesn't have any flow in the cyst wall. Inflamed cysts usually have a vessel that's parallel to the cyst wall, but again, it's outside the cyst in the pericystic tissues, but we can think of it as a parallel vessel in the wall. This is what an inflamed cyst looks like as opposed to a tumor. Why is it different? Well, here the vessel is just supplying the pericystic inflammation. Here the vessel has to pass through the wall to supply what's inside the cyst, so it tends to be oriented perpendicular. Have I ever seen a false negative? This is the only one. This was a necrotic grade 3 invasive ductal cancer that was totally liquefied centrally. It's the only time I've had a false negative on the parallel vessel sign. Now, how does this inflammation occur? Well, this is that simple cyst I showed you earlier that converted at 1 year to having low-level echoes, and then soon after that, she developed uniform isoechoic wall thickening, a red tender area, and a debris level inside it. This was fat. Proteinaceous debris generally doesn't cause inflammation. Lipids are exceedingly inflammatory. Just a tiny little trauma that causes a rent or a tear in the epithelium can let that fatty fluid get in contact with surrounding tissue, and that can incite an intense inflammation. So this usually happens in chronic cysts where the fat has had time to concentrate over time, and you can see it has parallel vessels in the wall. When we aspirate it, it aspirates completely, but we have that residual pericystic macrophage or lymphocytic infiltration. So we have a residual thickened wall. We have these 2 layers of foamy macrophages that are opposed to each other. These go away in 2 or 3 weeks. We follow dozens of these to see that they disappear in 2 to 3 weeks, and I don't follow them anymore. If I aspirate in what looks like a classically inflamed cyst and I get pus, I just send it for gram staining culture. I don't send it for cytology, and I don't get the short interval follow-up because I know it's going to go away in 2 to 3 weeks, and I know what's causing it. It's those foamy macrophages in the pericystic tissues. Now, you can get benign cysts that have thick fibrous walls, and they're really indistinguishable on ultrasound from acutely inflamed cysts. Usually they don't have a debris level anymore, and usually they don't have any hyperemia anymore, but the isoechoic wall thickening looks identical. The reason is it's simply the healed phase of acute inflammation. These foamy macrophages give way to fibrosis. But these aren't tender, and they don't cause redness. They're asymptomatic. So they look similar to inflamed cysts in terms of uniform wall thickening, but they generally don't have a debris level, they don't have hyperemia, and they're not tender. Now, the debris level can move quickly, as it is in this case, but usually it's so thick that it takes like 5 minutes to make it shift. So we can see that patient's on her back. I put her on her left side. It's only beginning to shift at 2 minutes, a little more at 3. It isn't until 5 minutes that it shifted to its new position, so you may have to wait a while to see it shift. This looks like a mural nodule, but in fact it's tumefactive pus in a chronically inflamed cyst. A shortcut is simply to do fremitus. That tumefactive pus is not attached to the wall, therefore it will not transmit fremitus into the cyst. If that had turned orange, it would be a mural nodule, and this would be a BI-RADS 4. For me, an inflamed cyst is a BI-RADS 2 or 3. So by not transmitting fremitus, I know that this is not a mural nodule, that this is just tumefactive pus or sludge. And I could prove that by waiting 10 minutes. This was so thick it took 10 minutes to crawl down the cyst in the decubitus position. When we aspirate these, we either get pus or bloody pus. We get this if we don't use Doppler for guidance. Remember, there's a lot of inflammatory vessels in the surrounding tissue. If you put on Doppler, you cannot get what's on top and you can get what's on bottom. What's the difference? If you get what's on top, you probably have to send it for cytology and gram stain and culture. If you get what's on the bottom, you just need to send it for gram stain and culture. I usually put them on diclox for 3 days while I'm waiting for the culture because it's usually a staph organism. Now, what we look for is tumor and inflammation. Now we can look for the definitive benign findings. Most of these are simply what makes a cyst complicated in the ACR Biorides lexicon. These are scintillating echoes. These are cholesterol crystals that are so light, just the energy of the ultrasound beam can make them move. Usually at the default ALARA as low as reasonably acceptable power settings, you won't get this. You have to manually turn the power up to get this, the transmit power. A simpler thing to do is simply turn on color power Doppler because that has even more energy than turning the ultrasound power all the way up. So I never bother turning up the ultrasound power anymore. I just turn on color power Doppler. Now, if you want to compare the two, this looks like a mural nodule and I've got my maximum transmit power and nothing changes. It looks like I got a mural nodule hanging from the roof, but you can see when I put on color, there's no mural nodule. That was just scintillating echoes that I couldn't make move because the acoustic radiation force of grayscale imaging is not as much as the acoustic radiation force of Doppler. Now, you can make these things move with pulse Doppler as well, and if you narrow your color gate, your sample volume, watch how much faster these go. So basically there's a spectrum of viscosities of fluid in these cysts, and the lowest viscosity can be moved by grayscale. The next level of viscosity can be moved by an open color gate. The next level of viscosity can be moved only by a narrow color gate. But there's some that's so viscous no amount of color can move it, but shear-wave elastography has even higher acoustic radiation force than does color or power Doppler. So you can see on the bottom that these are moving about 3 times a second because that's how often the shear wave pulse is going. But you can also see that it doesn't transmit shear wave, meaning that it's fluid. When you aspirate these, you aspirate completely, and on polarized light, you can see that they're birefringent crystals in there. They're usually cholesterol crystals. Fat fluid levels are extremely common on ultrasound. You can make them shift as well. We call these acorn cysts because it looks like the cap on an acorn. They aspirate completely, but you don't really see a little white fat layer when you aspirate them because the fat gets emulsified coming through the needle. But if you leave this upright on a desk for about an hour or two, a little white fat layer will form on the top. Another cause of acorn cyst is apricot metaplasia. That will never shift no matter how long you turn the patient to cube. The problem with fat fluid levels is they're viscous, just like tumefactive sludge. So it can take 2 minutes for these to shift. Now, you can find 10 of these on each side. If you're going to wait 5 minutes for these to shift, you're talking about 100 minutes for an ultrasound exam. So you need a shortcut that doesn't brain damage you to figure out that these are just fat fluid levels. So look at these two in the middle. These are obliquely oriented, convex posteriorly, concave anteriorly. This is the shape of a fat fluid level when it's in the process of transitioning. Sonographers who are efficient take an upright patient, get him in the room, get him down and scan him so fast that this is typically what the sonographer sees. And then by the time the radiologist comes in, it looks like this, and the radiologist says, what's the problem? It's a fat fluid level. So now as sonographers, you can short circuit the process and say, oh, that's a fat fluid level in the process of transitioning. And you can be pretty definitive about that. These are all fat fluid levels that I took at about between 2 and 3 minutes. Now, here's 2 acorn cysts side by side. One of these is apricot metaplasia, and one is a fat fluid level. This one on the left doesn't transmit, so that's simply a fat fluid level. The one on the right transmits fremidus. That's clearly attached. What's attached? Apricot metaplasia or papilloma. But this is a complex cyst on the right, complicated cyst with a fat fluid level on the left. So in a single view, you can see another shortcut. One shortcut is to look for the oblique sigmoid-shaped interface. The second is to see if fremidus transmits. Another thing you can do is elastography. Remember, shear waves will not transmit through fluid no matter how viscous. So if you have a fat fluid level, a shear wave will transmit through it. Another debris level is milk of calcium. Milk of calcium is psammoma bodies that are so small they can't be resolved on ultrasound. So we can only see a sheet of white that may correspond to several dozen psammoma bodies. And when we shift it, the whole sheet will slowly shift over about a minute or two. It doesn't move quickly. The other type of calcification that we can see are calcium oxalate crystals, and they look like little gallstones. They'll actually bounce down the back of the cyst wall. And you can see these are calcium oxalate crystals. Both of those are benign, but we can solve those with the cubitus imaging. In general, we can see more numerous and smaller calcifications with the mammography than ultrasound, but sometimes ultrasound can be more specific. We'll get non-specific collections of calcifications like this on the mammogram. We don't see classical teacups there, but when I put ultrasound, we can see that all these calcifications are in the dependent part of clustered microcysts. Again, this is a sweep through clustered microcysts containing multiple areas of milk of calcium and calcium oxalate crystals. Skin cysts are benign. They're sebaceous cysts or epidermal inclusion cysts, simply depending on whether there's been metaplasia in the fundus of the gland. They can be entirely within the skin, mostly subcutaneous with a claw of skin wrapping around them, or entirely subcutaneous with the gland neck and a white head or a black head obstructing it. These are definitively benign. Notice that I've required a standoff with a little healing and towing on each of these, especially here to show the obliquely oriented gland neck. Now, the indeterminate cystic or solid things can be called foam cyst, gel cyst, viscous cyst, inspissated cyst, or indeterminate cystic or solid. I just call them indeterminate. Usually fibroadenomas are a little more echogenic and ovoid in shape. Usually complicated cysts are a little rounder and more hypoechoic and have more through transmission. But that's a general rule. In individual cases, they can be indistinguishable. So what do we do to solve this? Well, we can try to clear the internal artifact with harmonics and compounding and focal zone placement. We can use Doppler. We can assume it's solid and characterize it. We can do elasto. We can attempt to aspirate, or we can do ultrasound-guided vacuum-assisted biopsy. This is Doppler. It shows that this is not a complicated cyst. This is either an encysted papilloma or a solid nodule. This is elastography. This is a cyst. This is not. Fibroadenomas look blue on shear-wave elastography. On the GE elastography, you look for the trialaminar blue, red, green appearance. And on Siemens and Philips, I don't know, what does Toshiba show? Blue, red, green? Okay. On some machines in grayscale mode, you get this targetoid appearance for cysts. So there's various ways that elastography can help you tell a complicated cyst from a solid nodule. The simplest thing to do is just assume it's solid and characterize it. It's almost always oval-shaped, well circumscribed, and you can call it BI-RADS 3 and then follow it. And if they're multiple, you can call it BI-RADS 2. So if they're multiple incidental, that's a simple technique. If you attempt to aspirate it, there's three possibilities. It won't aspirate at all, it'll partially aspirate, it'll completely aspirate, and you can't tell the difference. This could be a fibroadenoma. This could be a papilloma completely filling a cyst. This could be apricot metaplasia pulling a cyst, or it could just be proteinaceous debris or fatty debris. So these two will aspirate completely. Obviously, a solid nodule, a papilloma or a fibroadenoma won't aspirate. And apricot metaplasia won't aspirate at all either because it's attached all the way around. If it was partially filled with apricot metaplasia and partially filled with fat, it might partially aspirate. So, but there's nothing I found on ultrasound that would help me tell. I just have to put the needle in. This looked like a fibroadenoma, but aspirated completely. This looked like a cyst, but it didn't aspirate at all. But one of the things I can do when I think it's a cyst and it won't aspirate because it's got apricot metaplasia, I can rock the tip of the needle from the back to the front of the cyst. So here I've rocked it to the front, here I've rocked it to the back. And if you're using a vacutainer system, this stuff is too viscous to ever get in the glass part of the tube. You know, first of all, you have to leave it in. You want to use a little larger needle. You don't want to use a 20 gauge, you want to use an 18 gauge or a 16 gauge because it's too viscous to come through the little needle. Secondly, you don't want to look at the glass part of the tube and say, I didn't get anything. You want to make sure you look up inside the red cork. This stuff just, it doesn't squirt out, it crawls out. And you get a drop of either white or mucousy looking stuff in there. And if you stain it, you'll either get acellular debris or you'll get apricot clumps or apricot snouts that you've broken off by the process of rocking the needle. I don't like FNA in the breast, but you know, if you got a choice between a failed aspiration and FNA, you go for the FNA. And if all that fails, you can do ultrasound-guided vacuum-assisted biopsy. This is why you have to call as many cysts BI-RADS 2 as possible. We got a cyst with the debris level, we got an indeterminate cystic solid, we got a fat fluid level, we got acorn cyst with papillary apricot metaplasia. And every field of view in this patient looked that way. You have to use the rule of multiplicity. Any of these cysts, 4, 1, 3, or 2, can be called BI-RADS 2 if they're multiple and incidental bilaterally. On the other hand, if any one of these is the cause of a palpable lump or a mammographic abnormality, it's a BI-RADS 3 for this one, and maybe this one. This one you might have to call BI-RADS 4A. So it really matters whether you're seeing these incidentally or whether you're seeing these as the dominant clinical or mammographic finding. So in summary, the percentage of non-simple cysts is higher than it used to be because of better resolution and higher dynamic range. The gold standard was fuzzy till DVAB. We use the mammographic and solid nodule algorithm. We use BI-RADS categories. If it's BI-RADS 4, we need histology, and vacuum is better than core. If it's inflammation, it just needs aspiration and culture and sensitivity. And we have to use the rule of multiplicity to downgrade as many of these to BI-RADS 2 as we possibly can. Thank you.